My name is Kate, and I have the absolute pleasure of talking to you about my biggest passion, cats. I have some experience. So I started nursing in 2010 when I was 17. I was a junior nurse in a really small hospital. It was high volume. We did a lot of spays and neuters. I actually didn't grow up with any cats, and that hospital was my very first interaction with them. Due to my massive gap in knowledge and experience, I just loved the challenge of, cat, essentially. The weirdness and everything that they kind of threw at me I was obsessed with it. So I immersed myself in everything cats to learn more about them. So here I am today. I've been in vet med now for 16 years, and I still adore cats. So pretty much today we're going to go through trying to earn their approval, right? So the paradox of the cat, essentially, we spend our entire careers trying to make them cooperate, but cats aren't trying to cooperate. They're just trying to survive. So I'm going to go through lots of basics and stuff like that to give you guys kind of a nice little overview. The first thing that I'll kind of throw at you is, we've heard it before, cats are not small dogs. Sometimes we all need that reminder, especially when we're moving through a normal day at work, going from the bouncy golden retriever puppy to the noisy treatment room. In the noisy treatment room to the 10-year-old domestic short hair with unmanaged hypothyroidism sitting in her carrier in consult 2. The good boy out there is trying to make best friends with everyone in the clinic. He's eating his catheter. He's been plain silly. That cat in there, she's trying to survive. The facts that we have are, unlike dogs, cats have undergone relatively few evolutionary changes through domestication. Modern pet cats are genetically and behaviorally very similar to their wild ancestors. They haven't really changed. This means they still rely heavily on survival behaviors developed over thousands of years. Right. Unfortunately for us, cats haven't evolved to be veterinary patients. While dogs have undergone extensive selective breeding for cooperative behaviors with humans over thousands of years, cats have experienced far less behavioral modification and remain remarkably similar to their wild ancestors. From an evolutionary perspective, a cat's job is to survive by maintaining control over its environment. They're both the predator and the prey. Their survival strategy depends on several things. So control, maintaining choice over their environment and choosing how and when to interact. Hiding and concealment, avoiding detection when feeling vulnerable. Constant environmental scanning to identify potential threats and escape routes. Predictability, avoiding surprises and sudden changes and using familiar scent cues to determine safety and resources. All of this is pretty incompatible with anything and everything about the veterinary setting. Right, we remove their hiding places, remove their ability to escape, repeatedly move them between rooms and expose them to unfamiliar sounds and smells. We're activating their survival system from the second they walk in our door. Then we ask that tiny tiger to be compliant and accept whatever we need from them. The entire experience of the vet hospital is threatening. The car travel, unfamiliar sounds and offensive smells, barking dogs, loud treatment areas, bright, harsh lighting, removal from their carrier, multiple handling, repeated restraint. We've effectively removed every coping mechanism they evolved to use. Their fear response is therefore entirely normal. They're not being stubborn, naughty, or difficult. They are behaving exactly as evolution designed them to. And understanding this, it shifts from how do I make this cat cooperate and becomes how do I make this cat feel safe? Okay, so stress, why does it actually matter? Beyond, we're feeling sad for our little buddies that are very stressed. Stress isn't behavioral, it's physiological. So increases the heart rate, the blood pressure, respiratory rate, the temperature, blood glucose, decreases their appetite, immune function, and recovery. All of this is altered and impacted by stress. An example from earlier in the week here in this clinic, so here at Medipaws, I had a 10-year-old female spayed domestic short hair that we admitted for an upper intestinal endoscopy just for some biopsies. She was nervous, so she was referred over, and we were well versed by her regular vet that she doesn't tolerate handling very well and she would be pre-medicated with gabapentin. In consult, we were able to do a complete physical exam with her owner. Her admitting temp was 38.2. Within 90 minutes, so just after her induction, that had increased to 39.3. So that's the least obvious sign that we're often going to see in hospital. You'll see the heart rate, you'll see the respiratory rate. It's not often that we're repeating that temp. So now we're all thinking of those very worried cats that develop a temperature while in care. So sometimes the vet will say, let's keep them until it's more normal. We hate that. Every interaction can either increase or decrease physiological stress, and our job, we know, is easier, more enjoyable, and safer when our patients are less stressed. Research shows us we have higher client compliance and better outcomes for our patients. So I'm going to introduce you to some incredible resources throughout this talk that help build an understanding of behavior. They help us reduce unnecessary stress and hopefully make everyone's day a little easier. The first that I'm going to talk about is the Feline 5. So it's an exploration of personality in pet cats. It was published in 2017 and is a scientifically recognized personality model. So the 5 personality traits are broken down into neuroticism, so characterized by shyness, insecurity, fearfulness, and anxiety. Extroversion, so marked by a smart, curious, and playful nature. Dominance describes a bully-like assertive nature, usually seen when interacting with other cats in the environment. Impulsiveness represents erratic, reckless, or highly reactive behaviors that are generally unpredictable. And agreeableness reflects an affectionate, gentle, and friendly disposition. Personality determines the coping mechanisms, stress thresholds, and tolerance levels of our patients. Personality predicts our approach to these cats. Those naughty, spicy, aggressive cats might simply be high neuroticism patients with a very low tolerance for uncertainty. What that cat will generally appreciate is predictability, hiding, fewer interactions, and more time. The extroverted cat may tolerate exploration, food enrichment, and human interaction. Our handling should adapt to the cat, not the cat adapting to us. Next up is the fear, anxiety, and stress scale, so the FAS. It's developed by Fear-Free Happy Homes, who have incredible science-based behavior-led courses and guidelines for both cats and dogs, developed for individuals and whole clinics. They aim to prevent and reduce fear, anxiety, and stress in clinical settings. This is a free downloadable guide, and frankly, it's pretty easy to understand and can be used at all points throughout patient visits. Just going to run you through it. It's a little bit hard to see, so I'll kind of talk you through it a little bit. So 0, green down the bottom. Our patient is greeting us in a friendly, relaxed manner. We're proceeding as normal. 1, still green. Our patient is showing some aversion to interaction with a slight drop in the head, posture, and a little pupil dilation. We're still going to approach, but we're moving slowly and quietly. So number 2 is yellow. So we're kind of approaching that little warmer step. Our patient is showing moderate signs with ears turning to the side, posturing away, whiskers moving back. We're reducing our handling and providing a hiding option here. So number 3 is our yellow to red tinge. Our patient has a slight increase in respiratory rate or maybe holding its breath entirely. So looking directly at stimulus or us. We're pausing and we're modifying the plan here. There you go. 4, so we're pretty red now. Our patient is looking for the exit or frozen to the exam table. Pupils are dilated and the body is flat. We're stopping. We're definitely stopping here. We will consider options and add some sedation. Okay, so 5, we're pretty red. 5 is very red. Our patient's displaying defensive aggression, which is hissing, staring. We might be swatting. We've got our ears right back. The body is hunkered down. We might have offensive aggression. So leaning forward, ears forward, the lumbar peaked and the forelimbs dip. So that classic Halloween cat posture that we see. They're probably growling at this stage. We're immediately stopping the procedure. So any cats showing either offensive or defensive aggression, we're stopping and we're going to reassess. We're going to talk about our next plan. The higher the FAS score, the less we should proceed. We're going to start asking questions like, can this wait? Can we medicate? Can we combine procedures? Can we reduce handlers? Can we use their carrier? Can we hold and reassess later? So a little breakdown of those reds that we should all be quite worried about. When we monitor anesthesia, we aren't ignoring a heart rate that goes from 120 to 240. We shouldn't ignore an FAS that goes from 0 to 4 or 5 either. A patient can move from 0 to 5 in less than 60 seconds. We've seen this happen. The scale is dynamic, and our response to an increasing FAS score should be 2. If we recognize fear earlier and respond appropriately, we can change our plan before we create a fractious cat. The goal isn't to get the procedure done. The goal is to keep the cat emotionally safe while we're getting the procedure done. All right, so the next study that I'm going to talk about is one called Can You Handle It?, which is validating negative responses to restraint. It's a 2018 study that validated what we all, as nurses, felt like we knew. Now we know it. This is definitely nurse intuition. The more restraint we apply, the more negative responses we create. Cats are incredibly good communicators. They tell us when they're becoming uncomfortable, but those signs are generally subtle and easy to miss. By the time we see hissing, swatting, or biting, we've missed several early opportunities to intervene. This study also reinforced that adding more restraint doesn't improve cooperation. In many cases, it has the opposite effect and escalates the cat's fear and defensive behavior. Escalation in this study looked like head turning, ear rotation, pupil dilation, lip licking, tail flicking, freezing, vocalization, and defensive aggression. Cats communicate early and progressively. Aggression is often a late stage response, not a personality trait. Instead of asking, how can we hold this cat better? We should ask, why has this cat reached this point and what can we do to change it? The good old ISFM. So I'm sure everyone has heard of the International Society of Feline Medicine. They're leading the charge with the feline-friendly movement. So the cat-friendly clinics are popping up everywhere. We're going through our accreditation now. The ISFM actually has incredible, free, and easily accessible guidelines and resources online. So if you haven't had a look, have a look. It's incredible. It is free. A lot of it is free, and they have on-demand CPD. They publish guidelines focused on cat-friendly principles that are really simple. Less is more. Provide choice, control, predictability, and safety. We aren't being asked to create perfect feline-only hospitals. It's a dream. We are being asked to give cats back the coping mechanisms that we've taken away from them. Before we touch a cat, we should ask ourselves, have I removed their ability to hide? Have I removed their sense of control? Have I created unnecessary surprise? Do I need to touch this cat right now? Small changes can make a huge difference. Every interaction should answer the cat's only question. Am I safe? ISFM were one of the very first to study and validate that scruffing cats causes significant fear, stress, and anxiety. And just so that we're all clear, and we've said it, we're definitely not scruffing cats. All right, so all of that we're going to put into practice. So now we're going to tie it all together. The message, failing to prepare is preparing to fail. Communicate the plan before doing anything. 30 seconds can save you 20 minutes. Verbalize any information you already have and build a plan with the team. Delegate roles and discuss the goals of each interaction. Prepare your equipment. Every time we stop halfway through a procedure to find another tube, open another syringe, or ask someone to grab something, we're prolonging that interaction, adding noise, movement, and increasing that cat's FAS score. Pre-open syringes, needles, alcohol wipes, pre-lubricate thermometers, open fluorescein stains, flush catheter ports, stretch out the vet wrap. Have it all ready. We're fortunate here at Medipause to have multiple cat-only consultation rooms, a designated cat ward, and cat exam room. All of these spaces have very low foot traffic. They're quieter and they're calmer than the rest of the hospital. For most general practices, I know this isn't the case, and that's okay. With limited space, I'd recommend utilizing a consultation room for conscious cat exams and treatments. Avoid having them out in any open treatment areas unless they're well sedated or anesthetized. It's always okay to ask an owner to step out into the waiting room while we just complete an exam, take bloods, or place a catheter. Every room change increases stress and creates unnecessary transitions. This is a much better alternative to taking them out the back and walking past that golden retriever puppy that we talked about earlier. If we plan to admit to the hospital, prepare their bedroom and accommodation before you bring them in. I always refer to it as a bedroom. It's way less intimidating for owners and sounds way less like a prison cell. The necessary bits that we should have for husbandry. So hiding is critical. I love keeping cats in their own carrier if it's suitable. It needs to just be an easy carrier that you can visualize them in, easy for them to move in and out of freely, and easy for us to get them in and out of as well. If the carrier doesn't fit the brief, make sure they have an igloo or hiding box that makes them feel safe. Visual barriers are really important. They don't want to stare at that golden retriever puppy, and they definitely don't want to be watched while they consider all of their life choices that led to them sitting in this hospital. And another really simple part is remembering to separate all of their resources. No one wants to poop where they eat. All right, so the tools are pretty simple. They don't cost a lot of money. They're not fancy. I love a towel. It is the only tool for restraint you should ever really need. They provide warmth, both physically and emotionally, and support for them and us, and security, again, for them and for us. Every single interaction I have with a cat will in some way involve a towel. The second someone says, I have this cat, I'm already reaching for a towel. Most cats I'm handling don't require a burrito wrap, so please don't assume that this is a one size fits all and the only purpose of the towel. For some personality types, this will cause escalation, but in general, I would never handle a cat without a towel around. At the very least, their little feet deserve to be cushioned on the table. Carrier selection is really important. So the best carrier is a hard plastic with a top opening, a front opening, and clips that separate the top from the bottom. The best ones have removable halves, so the whole top half will come off with just the clips. It allows for examination and handling with significantly less stress, and we don't have to drag the cat out. We definitely don't want to be pouring cats out of carriers, so make sure we're having open conversations with owners if you feel that the type of carrier that they've come in with today isn't conducive to a good emotional state for their pet. A good carrier that comes apart easily with no fuss or unnecessary noises or movements can really change the entire visit for a cat. So Feliway synthetic pheromones, I do view them as potentially helpful, but not entirely transformational on their own. Synthetic pheromones may help some cats feel safer, but good feline medicine starts with handling and husbandry, not the diffuser. In saying that, though, still highly recommend them. So the secrets, these are just little things that I've collected, so I'm not going to gatekeep anything. If there's something on here that you guys also want more information on, we'll have a chat. One nurse working purposefully, quietly is always going to trump 3 nurses doing full body restraint. There aren't any fast or unpredictable movements, and every single touch on the patient is gentle and purposeful. So when we're generally handling, including the jugular, it's a cat, you do not need the same amount of pressure that you would for that golden retriever puppy. The most gentle touch with one finger will get the job done perfectly. Holding the paw for a cephalic catheter placement, you don't need to squish their little delicate toes or twist any joints. They're just little cats. If you're restraining the patient, even holding that elbow, the amount of pressure that you're using to extend that arm or to roll that vein, it doesn't take a lot. That is usually what induces the most reactivity in our patients. Okay, so we're working quietly, both in physical tasks that we do and conversations that we have in their space. I'm a firm believer in talking to your patients. My team can definitely vouch for that. In general, I'm loud and I have a lot to say. When I'm handling a cat, though, my tone will soften and the volume will drop significantly. I love topical anesthesia. Sorry, Mel. This is all I'm going to say on anesthesia. I promise. A little spritz of Intubes over the jugular just prior to sampling can be the magical difference between sample collection and no sample collection. While I love the EMLA and other lignocaine gels, the drawback is that it does take 20 odd minutes for peak effect, which means double handling and often the area of application. So if it's a cephalic vein that you've wrapped, it does need to be covered to prevent patient ingestion and interference. And I also have a theory that EMLA causes a bit of vasoconstriction, which does make it actually harder to catheterize. A warning that sometimes the smell and atomizing component can startle some cats. You might see like a little lip lick in response to that initial spritz, but it's usually very transient. Another one, controversial. All right, so using a 25 gauge or orange needle for a jugular sample on a jumpy cat. I am super okay with making people a little fired up on this. If anyone wants to have an argument, I'm here for it. So I work with several feline medics, and I can tell you now, we don't get any complaints on it. A 23 gauge is perfect for an adult cat. There's no reason to be using a 21 gauge or a black needle for any type of sampling on a cat. So those patients become very needle aversive very quickly. If we're using smaller gauges, use passive, slow, low suction to collect your sample and prevent cell trauma and clotting. I'm talking that 25 gauge with a 3 ml syringe attached. It'll take you a little bit, but I'm yet to have one clot. Okay, while we're making waves and bold statements here, a 25 gauge or yellow catheter is appropriate for most cat patients. If that's all your needle shy kitty needs to allow a catheter, why not? A Surflow 25 gauge catheter has a flow capacity of 20 mils a minute. That's massive. That is massive. If you've got a routine prophylactic procedure, you're not going to be using volumes of over 20 mils a minute. For most all non-emergent procedures, that's going to serve a 5-kilo cat perfectly. I will say adult cats getting a 25 gauge through their skin is the most tricky part. That's usually where you're going to have trouble. So again, you shouldn't really need a 20 gauge unless we're dealing with an emergency. And following the theme here, we're just stopping and changing the plan if any of those signs of escalation are happening. This is the most important thing that I can say this talk. And that sums up all of the things that I could remember to say to you guys. But I like to think that if cats could write the Google review for us, it would look a lot like this. They want minimal touching, excellent hiding opportunities. They want staff to respect their boundaries, and we'd love to hear that they tolerate a visit with us again. So, does anyone have any questions? Any questions? Did I? Thank you. Thank you. We're all happy? And we get the next one set up. Go for it. No, I think it's fine. Absolutely, you can say that. Yeah, absolutely. Yes. No. Yeah. So I would use a butterfly for the Abby and Joel blood bank. I definitely wouldn't. So for a normal jugular
We'll get started with our second talk. We've just unmuted the online people, so if someone could just in the chat online just let us know that you can hear us again, that would be great. But second speaker, as we said before, Mel, one of our lovely surgery nurses. So without further ado, Mel.
Cool. Hi everyone, so I'm going to talk about anaesthesia of our lovely feline patients. I'll give you a few tips and tricks, things we should and shouldn't do, and we'll take it from there. Cool, so from this you should be able to identify some feline specific anaesthetic considerations, perform effective patient preparation, recognise and manage some complications with them, and then especially with the cats, support a smooth recovery. So just very basic, just going to touch on our parameters for our cats. So their heart rates are generally higher, so we want them between 110 and 200, about 20 to 40 breaths per minute. Their temperatures do go a little bit higher than our dogs, so 38 to 39.2 is a relatively acceptable temperature. Our mean arterial blood pressure should be 60 if we're as a minimum. We don't want it to go below 60 on our oscillometric. And if you're using Doppler, we want it to be above 90. And then their end-tidal CO2 is lower than our dogs. So it's about 28 to 38 when we're using our capnograph. So just reiterating something that Kate said, cats are not small dogs, especially when we're anaesthetizing them. So having a kind of a small dog anesthesia approach with our cats will increase the risk of complications, and understanding cats is going to help us a little bit more with that. So they have a very unique physiology. They also have higher stress levels, as we have already spoken about. They have a greater risk of hypothermia. Okay. 1 second.
Let's get rid of, and then with this. No, not that. Yeah. Let me do this again. Window, cat talk.
Great. Sorry about that for everyone online. So again, just going through, I'll quickly go through these again. So cats have a unique physiology, high stress levels, a greater risk of hypothermia. Recovery can be more challenging with our cats as well. And they are masters at hiding disease and pain. So we're going to go through all of these in a slightly more detail, as well as they do have a smaller airway and laryngeal sensitivity. So we use the same anesthetic machine for all of our patients, but they are different patients, so we just have to approach it slightly differently. So their unique physiology and drug metabolism. So cats have a slightly different liver enzymes to dogs. So they have reduced, I can never pronounce this word, so glucuronidation capacity, which dogs have more of and then we don't. So their drug metabolism is different. So with this, propofol is metabolized differently with cats, so it can cause Heinz bodies if we are repeatedly using propofol. Now, it is relatively safe to use if you're doing a cat spay and it's all you've got, and that is perfectly fine to use. It's not going to cause any damage. However, if you are doing repeated procedures on your cat, so they need like bandage changes every day and you need to anesthetize them, they can get something called Heinz body production. So that is where it's an oxidative stress and it destroys the red blood cells, and they can then be destroyed faster than they can be produced because of the propofol. And they recommend if you need to do a CRI of propofol that you don't do it for longer than an hour. Obviously with cats we can use alfaxolone as well, so that is a lot safer to use, but if you need to use propofol we can use it. We then have our opioids, so our methadone, fentanyl, buprenorphine, butorphanol. Opioids are tolerated well with our patients. However, they can get a lot of euphoria and dysphoria.
So this is actually a cat that we did earlier this week, and he just had 0.2 mg per kg of methadone. As you can see, he looks very sad, and he also looks very cat high. His pupils are incredibly dilated. He became very very dysphoric. He was moving around everywhere, and this is also with 5 mics per kilo of medetomidine on board, and we had to give him a little top up to help him calm down a little bit. Some people say that you should use buprenorphine over methadone as they're not as sensitive to it, but if you're doing something like a spay, for example, would always recommend, if you can, to use methadone. Spays are very, very painful, and this is just a short acting kind of reaction, and you can always give them things like medetomidine and everything else to help them go through it. And if you're doing like an XLAP or anything like that and you want to put them on a fentanyl CRI, don't stop yourself from doing that because they need it. But just be mindful that they might be very dysphoric on recovery or in pre-med, as this guy was, and just know that you might need a little bit more sedation. So we've got our NSAIDs, so our meloxicam. They are very safe to use in our healthy patients, but cats are more sensitive to dehydration and renal hypoperfusion than dogs. So if you're worried that they might be hypotensive under anaesthesia, which, let's be real, most of our patients are, I would wait to give that until they're a bit more awake. Or you can just give it on recovery. Cats also need smaller doses as well, so their dose range is as a loading dose 0.1 mg per kg and then as a maintenance dose 0.05. We then have our alpha-2 agonists. So has anyone ever sedated a cat and given it the same kind of dose as a dog and then gone to be like, oh, it hasn't really worked? Has anyone ever had that before? Yeah. That is because, again, cats can be so stressed and then they have all this unique drug metabolism. They do need higher doses. All of the doses that we give with alpha-2 agonists will cause bradycardia and reduced cardiac output, which is very normal for the drug. And their heart rate can go down. Sometimes it can go down as low as 75, 80. I have seen a cat go down to 70 before. And I know it's very, very scary because we're used to, if their heart rate's below 100, that we need to do something about it. However, if their blood pressure is completely normal, it's very, very safe. If their heart rate does go below, then we would have to give it something to speed his heart rate up, like atropine. Then we have our benzodiazepines. So this is like midazolam, for example. Has anyone ever seen a cat that has been given midazolam with just an opioid? Anyone? Okay. The dysphoria is very, very real with midazolam. So cats become incredibly dysphoric. I have seen cats literally do somersaults and act like rabbits. They are just bouncing off of the walls. So it is a very, very good drug when it's mixed with a sedative. So it can cause extreme excitement, especially in our healthy patients. So if you're going to use it, I would use it after they've had a sedative if you need to use it. It does cause great muscle relaxation when they are very, very sleepy. So if you find that you've got a patient that he's just breathing quite a lot, but their depth is really good, giving them some midazolam will just help with that. Or are very, very sick cats. Things that you don't really want to give an alpha-2 to, but you've given them fentanyl and they're very sick and you just want to give them something else to reduce your ISO, that's when you'd want to reach for your benzodiazepine. And then big no, don't give any paracetamol. Because of the different liver enzymes, cats are unable to break down paracetamol, and it causes toxicity and liver failure. So we want to avoid that at all costs. And then last, we've just got ACP. So we use ACP quite a lot. However, in cats, it just doesn't work as well. If you did want it to work, you would probably have to give about 40 to 50 mics per kilo, and with an opioid to make it work. And then one of the big side effects that we have with ACP is it causes incredible vasodilation. So if we're then vasodilating our patient because we've had to give them that big of a dose to make them sedated, you're kind of not helping yourself. So would always recommend giving something else if you have it rather than ACP, just because otherwise you're going to kind of shoot yourself in the foot a little bit there with their blood pressure. And just obviously talking about all of these drugs, and I've given you all of the bad things about them. They are all very safe drugs to use for our feline patients, but you just need to know that they have slightly different doses. Obviously, paracetamol is a definite big no-no, but they can have slightly more profound effects or something that you wouldn't necessarily see with our canine patients. So just going to touch a little bit more on stress in our patients. So as we already know, cats are highly susceptible to stress in practice. And for us, that means that their heart rate can be elevated. They may require higher pre-med and induction doses, and they can also appear cardiovascularly stable. So if we have a cat that may have heart disease, if their heart is beating at 200 beats per minute, we are going to really struggle to hear a heart murmur or an arrhythmia, because it is going so quickly that it actually doesn't really give you time to hear much of it. Their blood pressure can also be quite elevated as well. So if you think you have a really stressed cat, just have that in mind, that then when you actually anesthetize them and relax them, everything may go down and is actually masking something that you didn't know. One good thing that we can use in our patients to reduce this stress is by giving gabapentin. It is very, very good at calming our cat patients, and I personally love it when you get quite an anxious cat, you give it some gabapentin, and within a couple of hours they are much more relaxed and you're actually able to do things with them. If you can, especially in practice, if you know that you've got a cat that is very stressed that's coming in for something the next day, you can always ask your vet to put them up some gabapentin. They give it the night before they come in, they give it the morning as well, and then hopefully you have a slightly more amenable cat that you can then do things with. So with illnesses. So as we know from what Kate said, evolution has adapted them to conceal signs of illnesses. They are a prey and predator species. So a cat, especially an older one, may still have disease present, even though you might not know about it. So the common diseases that they get are, so one of the big ones that I think most older cats that we all know is they've got kidney disease. So they may show by having increased renal parameters. Sometimes they could be quite dehydrated. And if they do have confirmed renal disease, always recommend keeping their blood pressure higher. So they've already lost 75% of their nephrons. We don't want them to lose any more. So I would generally treat blood pressure if their mean arterial pressure, if you're doing oscillometric, goes below 70, or your systolic goes below 100. So you just increase it by 10 on both. You also just need to see how dehydrated are they. So if they look quite dehydrated, you might want to give them some fluids in the morning, put them in an afternoon procedure slot, let them have some fluids, let those kidneys enjoy all that fluid, and then go later on. Cats can also be susceptible to diabetes as well. Especially for this, they can be PUPD, so check for, again, for signs of dehydration, and keep an eye on their blood glucose as well throughout the GA. Generally, I will measure before pre-med, about 15 minutes after induction, and then every 15 to 30 minutes, depending on what the measure is. If it's kind of borderline low or borderline getting quite high, measure it sooner. You just be prepared that you may need to give glucose if it's low, or potentially some more insulin. And you may need to avoid medetomidine with our diabetes cats. So it can be given in small doses if you have a very fractious cat. However, medetomidine does inhibit insulin release, so you have a risk of their blood glucose going too high. So if you are giving medetomidine, you might just need to check it a little bit more often. Our cats also love to get hyperthyroidism, so we all have seen those slightly crazy cats that are really, really skinny and are very, very, I don't know how, but very outgoing. They generally have a low body condition score, so they may get colder quicker, and they have a rapid metabolism. So they are going to metabolize all the drugs a lot quicker than what you expect sometimes. So you might need higher doses with those cats too. And then we have our cardiac disease as well. So I do have a slide on all of our cardiac considerations. So cardiac disease. So cats are more likely to have HCM. And actually, this is where our alpha-2 agonists help. So that's also another difference with dogs is they generally have mitral valve disease and we can't really use medetomidine. But our alpha-2 agonists really, really help with our cats. Because what happens is our heart is so rigid, and if it's going faster, it's not able to fill as well. So giving them medetomidine actually slows our heart down and gets us better contractility and helps us to increase that blood flow out of the heart and then into the body. And it's also more common than you think. A lot of cats will have HCM and you won't even know it. Maine Coons are very, very susceptible to HCM. So if you do have a Maine Coon in practice, almost treat them like they have HCM. I know most of them generally get diagnosed around the age of 2. I've also known a few cats die of HCM, Maine Coons, before the age of 2. So just be very careful if you have them. They don't always have a heart murmur either. So when we're listening to the chest, listening for a gallop rhythm, so it goes really, really fast and really, really slow, any respiratory wheezes, and if you have it, have an ECG on them because they can also have arrhythmias. So some arrhythmias can be normal in cats. So there is an arrhythmia called a right bundle branch block. And it kind of looks like this, and it looks very scary when you look at the ECG, but it's where the electrical activity in the right ventricle after the bundle of his is delayed. So it kind of looks very wide, very bizarre. But if you see this in practice, I think most cats, I remember when I was kind of in GP and I didn't really know much about ECGs at all, I'd look at this and think, oh, that's a normal cat ECG. I don't know if anyone's ever seen a cat ECG like this, but generally it is normal and you don't need to worry about it. But it can be a sign that there is structural abnormalities happening in the heart. So just let your vet know if you are worried about anything. Cats also have reduced electrical conductivity compared to dogs. So your ECG may be smaller, and your machine may mistake it for asystole. This is actually a cat that I did the other day, and you can see a small waveform, but the machine just constantly screams at you because it thinks your cat is an asystole, which it is not. But this is where you also just rely on your other parameters as well. So check your SpO2. If you have a capnograph, make sure that they've still got a good end tidal CO2, and then that also lets you know that your cat is definitely not in asystole. Cats with HCM, especially very severe HCM, may have VPCs, and they may have a run of them. So if you are worried that your cat that you're anesthetizing has HCM, just have a little bit of lidocaine ready just in case it goes into sustained ventricular tachycardia. But the occasional one is okay as long as your blood pressure is okay. So our pre-anesthetic assessment and their blood. So every anesthetic should start with a thorough assessment. So we want to obtain a complete medical history. If you can, get details about past anesthetics. That's just going to let you know if you need to plan for anything. If they've gone very severely bradycardic or medetomidine, for example, with hypotension, you might use a lower dose or just know to have your atropine ready. And then a full examination. Generally, I feel like vets will do this, but I think it's really important for us as nurses to do a full examination on them as well, if we can. Obviously, if you've got a very fractious cat, not to worry, or do it at the same time as your vet. Ask to listen to their heart, ask to feel their pulses, to have a look at them, just so that you know what's normal for them as well. Especially if the animal has got like a murmur, heart disease, or any lung disease with crackles or anything, it lets you guys know a baseline as well. So if you know what their heart murmur or their chest sounded like before, then if it got worse or something changed, you guys would then know about it. And then, yeah, this is just ET tube size, were they stable for past anesthetics as well. And then blood-wise. So if you can, as a minimum, a PCV-TP and a blood gas is going to give you a lot of information about your patient. So our PCV-TP is going to let you know how hydrated they are, if they're anemic or anything, and then our blood gas is going to give you all of the electrolytes and things like that as well, especially in our cats that could be blocked, like our blocked bladder cases. Our potassium is really important to know, so we just know if it's too high or too low. Generally it's quite high, but it just helps you then prepare for that next step. If you can, biochemistry, CBC, and a T4. Sometimes cats can be very borderline hypothyroid and you don't even know about it. And obviously biochemistry gives us all of our liver and renal parameters. If you do have a cat that has suspected renal disease, would 100% ask your vet if we can get at least a creatinine, just so you know what your kidneys are doing. So our common feline anesthesia risks. So hypothermia is that a lot more prone to, and I will go through these all separately. They can have a lot more airway complications, hypotension, and bradycardia. So with hypothermia, it's one of the most common anesthetic complications. So they have a large surface area to body mass, which means that they have more heat loss. They also have a loss of thermoregulation under anesthesia. So thermoregulation comes from our hypothalamus, which is also anesthetized, so it doesn't really work as well. So it's just we need to keep them nice and warm. When they're being clipped, they are going to lose body heat, as well as because they haven't got enough fur. And like as you can see, this is a cat and its whole abdomen is exposed. And as we know, they do like to curl up into balls and be they kind of keep their tummies covered quite a lot of the time, but then they're going to lose so much heat from this. Then you're going to add cold water and alcohol, which is just going to all evaporate and it's going to make them a lot colder. So what we want to do is utilize our patient warming. Believe it or not, there is a cat under this. You can kind of see his leg kind of at the back. I've got a bear hugger on the patient. There's a warming blanket underneath as well. And the whole cat is covered. So this cat had a wound, I think, on its leg. So the whole cat is covered, which is going to keep the cat warmer for longer. If you can, put socks on their feet. If you have jumpers and baby grows, if you're able to, pop them on. Before they're induced, you can pre-warm with a bear hugger. You can use some bubble wrap, and if you have them available as well, the heat moisture exchangers just help to make that oxygen not as cold when it's going flowing through the ET tube. So airway complications. So as we know, our cats do have smaller ET tubes. However, there was a study done at University of Sydney that actually says that the average 4-kilo cat who should be able, their tracheas are 4.5 millimeters long. So in theory, you should be able to get a 4.5 ET tube in, although that would be quite snug, but you should be able to get a 4 ET tube in. If you use a laryngoscope, it's going to enable you to have better airway vision and to open that larynx open a little bit more as well. So feline airways are so challenging, mainly because they are smaller than dogs retrospectively. And they can get laryngospasm. So laryngospasm is one of our most common airway complications. So when the larynx is stimulated, it causes the arytenoid cartilages to involuntarily close, and they do close incredibly tight. And it makes intubation difficult, almost near impossible. So it happens when they're in a much more lighter plane of anesthesia, so you can make them deeper. They actually need to be deeper for intubation than a surgical incision. So it might seem very excessive, you're giving a lot of Afaxone or propofol, but it will help you when you need to stop this from happening. The ET tube can kink. As we all know, size 3 or 4 ET tubes are so tiny that they're very easy to kink. Just keep an eye on your position of the tube and the position of the head, any weight on the tube. It can cause full airway obstruction, which on your capnograph you will see a shark fin. But if you don't have one, keep a very close eye on your breathing bag, on your patient's chest. Make sure that you can see some movement there. They also have a very fragile trachea. So it's unknown why cats' tracheas are so fragile. there is a thought that there's a difference within the muscles, but it generally is, you've probably all heard, I know definitely when I was in my training, I was always told be really, really careful with an ET tube cuff because it will cause tracheal necrosis or rupture. But using a cuffed ET tube is very, very safe. You just need to make sure you're doing your leak test correctly. So someone's breathing in, you're listening for a leak, and then slowly injecting some air into that cuff. A lot of studies and a lot of people will say don't use a syringe bigger than a 3 ml syringe. You're less likely to cause any damage that way, and then you're not also able to put loads of air in at the same time. They can also get some post-extubation airway swelling. So this can just happen, or sometimes if they've gone into laryngospasm and you've constantly tried to get a tube down there, it causes a lot of swelling, tissue damage, and sometimes bleeding. So on the top left-hand side of our screen here, this is something called a microcuff tube. It can't really tell from there, but the cuff itself is incredibly delicate, and it also helps you to get a bigger tube down your cat's throat, or the trachea, I should say, than the typical tubes that we have. If you can get them, they are amazing tubes to have just because it makes your life slightly easier, because sometimes you can see down there it's a really, really big airway, and then the thing that stops you from intubating a patient is the fact that the cuff is too big, where this kind of eliminates that. Like most cats, you're able to get a slightly bigger ET tube in. And if you are struggling with intubation and those arytenoid cartilages have decided to go into laryngospasm, or you're just really struggling because every time you go near it, kind of they decide to just close them off, you can get a rigid dog cath, either a 4 or 6 French, which is just at the bottom here, and then get a 3 ml syringe, and then the end of a 7 ET tube will fit into the end of a 3 ml syringe, and then you can actually very carefully insert the rigid UCath, and then you can give oxygen through that. So if you're really struggling and you just want to be like, I need to get some oxygen into my patient because they're going cyanotic or anything, you can give them some oxygen. Once they are a little bit happier, you can then cut the end off of that rigid UCath and then use it as a stylet. And that will then, you have direct access into that larynx, into that trachea, and then you can thread a tube over the top. And it gives you a little bit more time as well, just to kind of take a breath and not stress out as much. Then we've got hypotension. Again, this is a very common thing with our cats under anaesthesia. They just get so vasodilated from the ISO. So the first things that I do if we have hypotension is I check the blood pressure cuff, check it's on correctly, it hasn't slipped, change the limb if possible. Let your blood pressure circulate again. If it's gone up, great. If not, check your depth. Can we turn our ISO down? Or is it an appropriate level? Has it been on 2 for the last 15 minutes and actually we could turn it down slightly? Or like especially what is our heart rate as well? So if our heart rate's really high and we're hypotensive, do we need to speed up that heart rate? So if we've given medetomidine, it's gone into phase 2 and our heart rate has still stayed at 70, but our blood pressure does sit at 58, give a little bit of atropine and that will then speed our heart rate up a little bit. So as we said, what number do we want our blood pressure above? We want it either at 60 or 90, or if we've got cats with renal disease, we want it above 70 or 100. And then what causes our hypotension under anesthetic? So it's excessive depth causes vasodilation, like our ISO. If they're hypovolemic or are dehydrated. So if we know that they have had like a loss of blood or anything like that, or they haven't eaten for the past 2 days, which sometimes our cats don't want to do, they may need some fluid boluses, but it's just very important to remember cats can get fluid overloaded very, very quickly, especially our renal patients that may have been dehydrated for a long time. So give 3 ml per kilo over about 5 to 10 minutes, reassess, and then you can give some more. And as we said, blood loss and then bradycardia as well which will cause some hypotension. So I've kind of already touched on this before, but bradycardia. So what do we class as bradycardia? So that is our heart rate less than 100 beats per minute. And the reason why we class that is because cats, as I said before, just do need a higher heart rate to be able to maintain their cardiac output better. So they need a high heart rate, and then lower than 100 can also cause some reduced tissue perfusion as well and reduce cardiac output. So as I said, if you've used medetomidine and it's in the first like 15 minutes and you've got a really good blood pressure, that's fine. If you haven't used medetomidine and their heart rate's low, we do need to speed it up a little bit, and that could be some causes of hypotension as well. And then so we've got our pre-medication. So why do we pre-medicate? It reduces anxiety, and as we know, our cats have a lot of anxiety in hospital, so that just makes things a little bit better for them, provides analgesia, it reduces our induction requirements, and then it's max bearing, so it reduces our ISO as well. If you have an IV in place, which some of our cats will let us do, you do need just use smaller doses. So I generally, for a cat spay or a cat extract, for example, use 0.2 of methadone for IV, and then 5 to 7 mics per kilo of medetomidine. But if your cat is stressed and you can't get near it, I am your cat. If your cat is very, very wriggly and you're just really struggling with IV placement, generally I would go with a cervical, so in their neck for IM pre-medication. But if your cat is kind of hissing at you, lunging at you, seems incredibly stressed, obviously we're not going to want to go near that head. We're going to want to stay as far away from it as possible. So have another person with you. Personally, depending on the cat, but generally throw a towel over their head so that you don't get bitten, and then you can jab it in their bum or their leg. So drugs wise, we're going to use our alpha-2 agonists where we can, because they're very, very good sedatives, especially IM. You'd probably want to go at least 10 to 15, depending on your cat. Using our opioids, so our methadones, buprenorphine, and if they're already on it, some fentanyl. Again, we can use our benzodiazepines, but use with caution, and especially if only using with an opioid. And we can use alfaxolone IM as well. It is sometimes can be a big volume in our slightly bigger cats, and in general, like a 1 or 2 mg per kg dose in a 3 kilo cat will be about 0.3 to 0.6 mils. But if you're really struggling and you can't use an alpha-2 agonist, for example, or you've sedated them with methadone and midazolam and they're bouncing off the walls, alfaxolone will also be your best friend and help get them down. And then for our induction, so this is one of the highest risks times in anaesthesia. So have an intubation tray ready. So in the bottom right hand corner, this is just what we use for our induction trays. So I have ET tubes, a blood pressure cuff, a laryngoscope. I've got a HME, which we use, some ECG dots, tube tie, intubees, and some eye lube as well. So I have everything there in one space where I don't need to run around doing things. Again, use propofol or alfaxolone for your induction. Expect apnea. So when they are induced, they are going to be apneic. Most patients will be apneic because that is one of the side effects of our propofol and alfaxolone. So you may need to give them a few breaths just to make sure that they're doing okay, and then they're getting that ISO in as well. If they're not breathing and then you do suddenly let them just decide to breathe, they will wake up quicker. And have an ECG on if you can, or check for their pulses. Again, this is one of the highest risks that they could potentially crash, especially our sick patients. So the more monitoring you have on at the start, the better. So then our monitoring under GA, if you have a monitor, I would recommend connecting everything, even if it's just for a minor procedure. I know the Mindray ones have a cat setting on them, so use that cat setting because it helps you quite a lot. It has different values for their heart rates and blood pressures and capnography as well. And it also will help with your blood pressure. So the way that a lot of the oscillometric machines work is by patient size. So having the cat setting will help you with that. So monitoring wise, as I said, we want our capnograph, ECG, blood pressure, SpO2, and then temperature as well. Either a lot of the machines have the probe which you can use esophageal or rectally, or even just a thermometer so you can keep an eye on their temperature. Because they will get cold a lot quicker, keep their warming on from the start. Even if you've got a cat that starts at 38.5 or 39, stick some warming on it because they will get cold incredibly quickly. So with our analgesia, as I kind of touched on before, kind of reminding to utilize our opioids. And again, cat sprays can be very painful. So if you can, use your methadone over your buprenorphine, because it does provide some better analgesia. But then if you're worried or you want your cat to go, like the cat obviously will go home, you can give some buprenorphine 4 hours after. They have a longer lasting analgesia and they're not as high. Use your local blocks, especially for your dental patients. So the maxillary and the mandibular blocks. You can use bupivacaine or lidocaine. Your bupivacaine takes 30 minutes to become in effect, but it does last for 6 to 8 hours. So if they're going home that same night, they're going to have a lot of analgesia when they go home. Lidocaine takes about 5 to 10 minutes onset, but it only lasts an hour. So just keep an eye on that. If your patient is reactive under GA, don't just increase your ISO or your alfaxolone. Look at what your surgeon's doing and actually treat, if you think they're painful, treat that pain. So alfaxolone and propofol and even ISO doesn't stop the pain. That is still going to be there. So if you have checked their depth, they've got no jaw tone, they've got no blink, they've got no ear flick, then give them something. They might need some some medetomidine, for example, just if they need more sedative, or they might just need analgesia, which is also going to help your recovery as well. And then on their recovery, these are all lovely cats that have after recovery. So this is the most critical time. And so when do we extubate? So we extubate when they have a consistent ear flick, and a blink. If you let cats swallow, they are more likely to get laryngospasm. So I know it feels very weird when we extubate them and they're not fully lifting their head or swallowing, but it is a lot safer for them. And just have something ready just in case they were to go cyanotic and they were to have laryngospasm, have something ready that you can intubate them again. Big one, deflate your cuff. As we've already gone over, the tracheas are highly sensitive, so you want to deflate that cuff fully before we extubate. Stay with them until they are lifting up their head. Sometimes they may be very, very dysphoric. I know I've seen many a cat spay that you've extubated them, you've given them a couple of seconds and they're fine, and then they have done somersaults in their kennel. So have some sedation ready and close by to give to them so they don't hurt themselves or us. And if you can, recover them in a quiet room away from dogs. Dogs barking is going to make them a lot more stressed, especially if they're already stressed after being anesthetized, and everything else that's gone on. So have them nice and quiet, have some nice cat music going on, and that's going to make your life a little bit easier. And then pain scoring. So as we said, cats are also a master of hiding pain. So the pain score that we use on cats is our feline grimace scale. And the reason why I love this so much is because you can pain score a cat from a kennel and you don't even need to touch them. So what it measures is our ear position, orbital tightening, muzzle tension, their whisker change, and their head position. So obviously with things like Scottish folds, they're really hard to tell because they have incredibly flat ears, but then you can go through all the other things as well. So I'm going to give you an example. So this was a cat that we had that actually had a foreign body. So his ears are pulled apart and they are down. So I would class this as a 2. The eyes are very, very squinted. So again, another 2. It's kind of hard to see because she's so low to the floor, but her muzzle is kind of very dropped. It hasn't got that tight cat kind of muzzle that you would want. And her whiskers are very tight to her face. So with the whiskers, it's more how they're like protruding outwards. So if they're very, very close to their face, it means that they're in pain. And then their head carriage. So if their head carriage is below their body, they are also in pain. So we put this cat on a fentanyl CRI, and within 20 minutes we had a very, very big difference. She was quite a sweetheart, actually. So then, as you can see, her ears, I'd now score a 1. They're not fully upright, but they are there. So we've gone from a 10 out of 10 from the last one to her ears are better. Her eyes are a lot more open, so I'd class that as a 0. Her muzzle is relatively normal, her whiskers are more out, and then her head carriage is gone up. So we've had a cat that was incredibly painful. We've given her some fentanyl, and 20 minutes later, she's gone from a 10 out of 10 pain to probably a 1 or 2 out of 10. So they might not always show us, well, they will always show us that they're in pain, but it's nicer because then we didn't actually have to go and palpate her abdomen. We knew she had a foreign body that was potentially rupturing, so we don't want to go and squeeze that, and we can do it from there. So just a couple of take-home points. So just remembering cats aren't small dogs. They have very different, unique physiologies, behaviors, and drug metabolism. Preparation prevents our complications. So try and identify risks before induction where possible. Our airway management can be difficult. Go slow, be prepared, monitor everything closely, and act early. And recovery is a part of our anaesthesia, and it is most likely when our cats are going to crash. So stay with them a little bit longer. Does anyone have any questions? That's cool. Hope you guys enjoyed it.
Before everyone gets up, your CPD certificates will be sent out to you at the start of next week by email. And we're also going to send out a quick survey. If you could just spend a couple of minutes filling it in, just so we can do these better for you guys next time. We just want to know what we can improve on, what you enjoyed, all of that. So that would be really appreciated. And I think everyone enjoyed tonight. Thanks, guys.